Okay, I think we've got it back on. You guys can check. And Abhishek, you need to shoot the foot evaluation from the beginning again.
Okay, I think someone just wrote on the chat that it got disconnected at foot progression angle. Were you talking about foot progression angle, Miten?
Which is funny because we would like you to talk about it. So, yes, so I concluded saying that we need to evaluate everything from the core to the hip to the knee, check for femoral anteversion, tibial extortion, get the history and the examination right. And I covered everything except the foot. And we spoke about hypermobile individuals visiting us more often. And then Abhishek was just about to begin about how to evaluate the feet in these patients with anterior knee pain.
Okay. So I think how I would evaluate is like, yes, proper exposure from knee downwards. You need to check what the Q angle is or how valgus or whatever the alignment of the knee is, and also look at or examine the feet in standing position so that you can see from behind how bad the hind foot is in valgus. The deformity of the foot is three-dimensional. So there is hind foot valgus, there is a collapse of medial arch. So that's in the superior inferior plane, that's the collapse of the medial arch. At the same time, the forefoot also supinates. That's a compensatory supination to compensate for the midfoot collapse that happens. So what that progresses is you need to check which joints are subluxated or at which joint there is this deformity happening in the feet, because there are joints at very shorter distances in the feet as compared to the other parts of the leg. So at the talocalcaneal joint, there can be a valgus. At the talonavicular or navicular-cuneiform joint, that's the medial ray, either of them or both of them might show plantar subluxation. That means it's a collapse. So these two are the ones that you need
Is
to
there
check.
any easy clinical way to differentiate all of these?
Ideally, a standing X-ray will tell you where the joint has collapsed, because clinically, if you try to palpate it, they are so close to each other. Add to that the tendons which are overrunning the joints, it becomes little difficult. I'm not saying it's impossible, but yes, there is a slightly longer learning curve to it. But yes, there would be some tenderness at joints which are subluxed. But again, as we just mentioned, in hyperlax or hypermobile individuals, they might be absolutely painless. These joints might sublux
Right.
very easily as compared to in someone who's inflammatory or rheumatoid, where there might have some synovitis and pain in these areas. So that would be one point. Number two, this is also very important for for us to prescribe orthotics, because the apex of your orthotics, or when you write about an arch support, you need to also write at which point in your medial arch you want the apex to be located, because more often than not it is the talonavicular joint, but we have enough patients who will have a navicular cuneiform joint collapse, or even a tarsometatarsal, like a cuneiform first metatarsal joint collapse also. So the apex has to be at that point where the arch is collapsing, and that's best
So if you
judged by
don't have
standing
an
X-ray.
orthotic that has the apex at that particular point, is it better to not prescribe an orthotic at all, or generic orthotics are somewhere in the middle?
I think generic orthotics are somewhere in the middle, because the apex might not be there, but some part of the curve which might be slightly higher than the other flatter portion of the orthotic might still act there. But again, if your apex is not at that point, then you are more likely to cause a bit more harm, or because they are not comfortable with this, because their normal joint is subjected to offloading or torsional forces than what their ideal joint which should have been targeted. So
Right.
it's like, if your knee is a problem and if I'm giving you an ankle brace, your ankle will start hurting. So that's the
Right.
example that I try to give, because it's very important that you prescribe orthotics at the correct joint. So it's
So, and
important.
when you find these out, so what the diagnosis is, pes planus versus dynamic pes planus, or what? So, of course, we didn't cover what's rigid and what's dynamic.
So
So,
I think it's very easy. Rigid means someone whose subtalar joint is fixed. That means a patient who's flat-footed and the foot is not correcting on manual subtalar
This is
inversion.
always bilateral.
Rigid, unless trauma, is always bilateral, because, or there would be some variations in it, because there might be, say, like the other causes for rigid flat foot can be a tarsal coalition or peroneal spastic flat foot or something like that, where there is a neurological cause. So these causes are more often developmental and will be seen more often than not in bilateral patients as compared to unilateral post-traumatic cases. More often than not, these patients, uh, because they have been flat-footed from childhood, would
Right.
have less problems as compared to, because their body is well compensated for it. So
Right.
people who are flexible flat-footed, who were kind of managing up till now, and sudden overload as the dancer, who's kind of
Right.
uh, the practice and the training has kind of progressed suddenly or increased suddenly, or a marathon runner who has shift from a normal running shoe to a minimalistic shoe, would get all of these symptoms more often than someone who's rigid flat footed. Rigid flat footed, whether you give him insole or not insole or anything, his arches are not going to change. So rigid insole, just
So they're
rigid
not
flat foot.
to be prescribed to those with a
No,
rigid
so
flat.
rigid flat foot, you just need to primarily work on the Achilles, which again is a very important driver of your foot. Again, that's one more point that I would examine, whether there is calf tightness. Calf tightness, calf has two muscles, gastrocnemius and soleus. You
Right.
need to identify which one is tight and you need to address that muscle stretching specifically.
Right.
Again, because there is a hind foot valgus, which means the pull of the Achilles, which is the strongest tendon of the body, is acting more lateral to the midline. I hope I'm understand. I'm
Yes.
getting this through. Then the Achilles also acts like an everter and aggravates the flat foot. So it's very important that if you are prescribing an orthotic which is going to neutralize your calf or neutralize your hind foot, you need to stretch your Achilles also equally well, so that these things will act in a more correct plane and the force vector is generated at neutral hind foot and not at an everted hind foot. So all those things are very
So
important.
we
If
keep talking of hind foot and midfoot. Does the forefoot play any role?
Yes, it does play a big role, because while normal gait walking, a normal walking gait cycle, it is more hind foot, midfoot, like hind foot, then midfoot rocker, and then forefoot. But if someone who's active, where say like a runner or a dancer, the force momentum is such that the hips are slightly flexed during activities, that pushes the center of gravity more anteriorly and towards the midfoot and forefoot. So
Hmm.
again, if someone who's a dynamic flat footer or dynamic pace planners, their center of gravity, like that means someone who's while running is having a flat foot or dancing is having a flat foot, their center of gravity is more anteriorly, that's more in the midfoot and forefoot. So those cases, again, you need to check why, or rather what etiology is causing them to uh, destabilize their feet, and subsequently the biokinetic chain is getting affected. Very often than not, it's more of the intrinsic muscles or long flexor contractures. That means you will see them having claw toes, and these claw toes are dynamic. So when you kind of put your arch or put their feet down and stretch your toes, you will see the arch, but when they are acting on their own, there might be flat feeted. So again, those patients, again, insoles are not going to help, but they are going to need more of stretching exercises for their long flexors, that's FHL, FDL, as well as intrinsic. That means they need more of plantar structure stretches as compared to Achilles also. So
Okay.
something like that. So it's kind of both. So in a dynamic, you need
We'll
more of
just
mid to
cover the
forefoot.
management in a bit. So, like you
Yes,
said, I'm just going to repeat what you spoke on in terms of investigations. So, you would want a standing AP and a lateral
correct,
of the foot.
correct.
Would you do it routinely in all patients? Like,
Uh,
just assuming that the patient's not coming to you with predominant foot complaints, it's anterior knee pain, but you found, uh, but you're looking for a flat foot, then you won't do it, right?
no, if it's primarily anterior knee pain patient, I would not, because they will run away from me. But
Right.
if someone who's come to me for flat foot, I would do it. But at the same time, someone who's high demand as a dancer or a runner or something, I won't hesitate to explain the patient that I want to prescribe an orthotic for this. And that is why I need to get an standing x-ray, which will help me kind of tell you where exactly I need to locate my apex of my or medial arch support. So more often than not, I think patients are very happy to get investigated because they would themselves get proper correct prescription for orthotics rather than just off the shelf orthotics, because more often than not these patients would have tried orthotics because of their running coaches and other people who they kind of bump into very often than not.
Right. So I'm just sharing my screen. I'll just go through
Yes.
the investigations. So we stopped, probably the YouTube link stopped at this slide where we spoke of the evaluation. But then I went on to say that 3 things must check: maybe a step down task from the board, a single leg squat, and most of these patients would have a quadriceps avoidance gait that you can look for. And then I frankly, for anterior knee pain patients, believe that it's predominantly a clinical diagnosis. I wouldn't like to subject them to any investigations, knowing the fact that a skyline would probably elicit a tilt and a glide. And all of this that I'm showing, you can see that this patient has, the 25-year-old female dancer has a valgus alignment. And you can, of course, even look for if these patients have trochlear dysplasia on the lateral x-rays. But routinely, first visit, acute anterior knee pain, I won't subject them to any investigation. If you have a patient with chronic patellar instability more than pain, and then you can go on to do the MRIs and all, but we don't want to discuss that here. One thing in particular, if you have patients who are not responding to rehab and have very focal anteromedial pain, then those are the ones I would subject them to an MRI, and the skyline would, axial section would probably show something like this in picture, which is a medial synovial plica that's hypertrophied. And this is a different diagnosis needing different treatment. So now we come on to management. And as far as the knee is concerned, I think this diagrams to be printed out and shown to every patient, where you must tell them that this is like an iceberg phenomenon. So you have to reduce your load, you have to reduce the frequency. And there are 4 things that essentially must cover treatment. Most of the physiotherapists that we see, or the clinicians that treat these patients, just focus on trying to improve the patella movement. But as you can see, there is a progression, and bigger handwriting means it's more important. So first and most important is trying to make the patient understand how to reduce the load. So whatever they are doing that's supraphysiologic and that has led to this kind of pain has to be stopped, especially all loaded knee flexion. So you can think of asking them to not use Indian toilets, no squat positions, no Surya Namaskar, Padmasan, Vajrasan, because getting up from these positions is going to lead to issues. And of course, no jogging, jumping, running, dancing, Zumba, till you start improving your patella position and patella movement. And most of the chronic patients, then there is a psychological overlay that we need to work on. So how do you improve the patella position? The idea of treatment is that most of the management must have a mirror in place, because everything that you're trying to do is the end point is trying to improve how the patient walks, stands, gets up from a sitting position on a daily basis. And this can only be done with feedback. So most of these treatments, we recommend that there should be a mirror. The simplest first thing that you can do is ask the patient to stand and squeeze their glutes, and they will be able to see that there's the kneecaps moving, because there's external rotation of the femur, and they can witness this movement. Once they appreciate this, then most of the other treatment becomes much easier to convince. They must learn to watch their patella. Now, you can improve patella position with taping, but the idea is think about the infrapatellar fat pad always. Don't tape too low. Think of releasing and stretching, not only taping. So everything on the lateral side of the knee, behind, and everything must stretch, stretch, stretch. And you must teach the patient, if you're taping the patient in an ideal scenario, it should stay throughout the day. And if they can't visit you or they're seeing you twice a week, then whether it's kinesio taping or McConnell or whatever you're following, There are certain papers that talk about sham taping as well, which don't follow the principles. But if it's on, then it does improve the patella tracking, the position. And then you work on movements. So how you work on movements is, you can't just focus on strengthening. In fact, strengthening is the last thing we want. We want to change the way the patient moves, and that's done with neuromuscular weight bearing exercises. So it's very difficult to describe this picture, but 45 degrees to the wall and the knee just unlocked, with the other leg, the knee bent, and you try and tilt the pelvis posteriorly and ask the patient to squeeze their glutes. And then you can see, that's like the first exercise we begin. And you must teach them small things, like when they get up, then their knee must lie between their second and third toes, and when they walk and they stand, and everything needs to improve, with a focus on stretching, improving the flexibility everywhere, the anterior hip, improving the external rotators, the hip abductors. Stretch, 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 and think of strengthening just at the last. So even simple things like extending the leg, think of stretching the hamstrings rather than activating the quads. So short arc quadriceps exercises, the SLRs, yes, they are part of the rehab protocol, but anterior knee pain rehabilitation has moved much ahead of that. And there are a lot of these combination of movements that you can teach these patients to change the way the patient moves. So I'm going to stop screen sharing here. And Abhishek, so we spoke of insoles being part of the management protocol. Abhishek, are you there?
Hello?
Yeah. So like I said, so most of us, of course, this discussion is not heading towards surgery at all. We're thinking of the patient going to the physiotherapist and then starting treatment. So then they've evaluated everything. They know what's to be done with the knee. And as far as the foot is concerned, assuming that insoles ka humko sab aata hai, what is the other thing that needs to be done after you've evaluated, like you just said?
I think for an anterior knee pain for in a dancer, primarily for the feet, I would also like them to teach them some exercises. So in the feet exercises, I would think, as we just discussed, that we need proper gastrosoleus isolated stretching exercises, because that's very important. Calf as the only big muscle that will can drive the calf either ways, like everted or inverted. Along with that, we want some posteromedial structure strengthening. So
Right.
how do we do that is, like, we want them to start their inversion strengthening, because that's a very inversion strengthening with foot plantar flex, because that would get the tibialis posterior to start firing in a better coordinated manner. And add to that some medial intrinsics. How do you do that? I think there is a good article on foot core muscle strengthening program, which is
Lovely.
2016 foot core. So it's like how the back is important, how the lower back and anterior abdominal muscles are important for your spine and pelvic
Yeah.
stability.
And
Similarly,
I
there
missed
are
out on mentioning that proprioception is very
yeah.
important.
So
So
I think the exercise that you just showed, the girl who was doing that to 45 degrees, also trains her to proprioception, because that there is a balance component that is coming inherently to that drill that we've just discussed. So add to that foot intrinsics, foot core. Foot core means all the smaller muscles of the feet which are plantar. You need to strengthen them. So it's not that small intrinsic muscles cannot be strengthened. They can be strengthened really well. But yeah, it's a kind of, it needs around 4 to 6 weeks of
what
training.
about the do's and don'ts? So like I
Uh,
said, I don't want certain loaded knee flexion. So what is
hmm.
allowed, what's not allowed, and what's the advice on running? So like barefoot and shoes and
uh,
leather shoes at
Don'ts,
work.
I don't think there are many don'ts in it, because at 25, most of the structural development has happened. So what I would do is avoid, or rather, while running or any high impact activities which are shoed activities, especially running, office going, where they're going to stand. So if they are, like, as they say, as some of our physios or surgeons, or someone who has a standing job where they involve a lot of standing activities, I would get them into a good insole in their normal activities, because what does that insole do is insole would avoid further stretching or further overloading or further subluxation of that joint, which is kind of prone to subluxate, so either a talonavicular or navicular cuneiform. So that support will kind of help them strengthen their intrinsic and extrinsic muscles better with structural stability in form of an arch support. So don'ts would be avoid long standing unsupported, that would be a don't. Running preferably in good running shoes which are well cushioned and protected arch is necessary. Otherwise, what happens is if they run with minimalistic shoes, I'm not saying that they can't run with minimalistic shoes.
So we just lost you
Footed
there
people
probably.
can run with minimalistic shoes with
Right.
proper foot intrinsic tone. So until they develop a good intrinsic tone, so I have a few patients who kind of run minimalistic bare feet and are flat footed, but their foot intrinsics are so good that they can actually hold a pen and draw a circle or a square or something, holding a
Like we
pen
were
in.
discussing, we just saw PT Usha's video on Facebook that's
Yeah,
circulating, right? And
correct.
so the
Absolutely.
last 10
So
meters of her dash, and she really has
yeah, she has a overpronated foot, but that's something that she is naturally built with. So we don't want anything to change their dynamics drastically unless something's stopping them from doing or achieving their goal which they intend to achieve. So had PT Usha kind of not progressing beyond a certain point, then maybe there would have been some role to play in it. But otherwise, I think you ask 99 out of 100 sensible physicians who would see her would say that that's the natural way of doing it. So don't go about anything about anywhere.
right.
So I
And
think insoles at a correct place and good stretching and strengthening of foot intrinsics is what we are looking at and nothing else.
excellent. And the last part, say, have you offered surgery for any of the professional athletes that you've seen who initially said that I have knee pain, but of course started having foot complaints too, which affected their game? Has there been a scenario like that?
Uh, I have offered surgery or I have performed surgery on professional athletes who have come to me for flat foot related
Right,
problems.
right,
But
right,
someone who's come to me or someone who's come to say like you
right,
for a knee problem,
right.
and I have just been told to look at their feet and advise, I would not consider a surgery
Perfect,
because that's
perfect.
not their problem. I
And
would
for us
rather
as
send
well,
them to my
like
physios. Yeah,
like I mentioned right at the beginning, we tend to differentiate these patients into pain versus instability, and
correct.
we would offer surgery only for the instability cohort. By far and large,
Absolutely.
in the last 6 years of practice, I have offered surgery to somebody with pain that's recalcitrant in the chronic position just once. And that's this slide just goes to tell people the difference, that if we are thinking of instability, then everything is structured around building more stability. So MPFL reconstruction is what's done, and then depending on how the trochlea is doing or the patella is doing, we would offer other surgeries with that. But it's for instability, not for anterior knee pain. Though that the one patient that I spoke about, we do something called as an AMZ. That's anteromedialization, first described and brought into popular culture by Fulkerson, where we just have this sliver of tibial tuberosity that we bring forward. So that creates something we call as a Mackay effect. It reduces the patellofemoral overload. And of course, we want to change the Q angle, or for orthopedic surgeons, the TTTG distance. So we medialize the tibial tuberosity. So we anteriorize and medialize and fix the tibial tuberosity, and this changes the dynamic patellofemoral biomechanics, and it can dramatically affect the anterior knee pain. But like we discussed, the incidence is really, 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 really low. So anything to add to that, Abhishek?
No, I think as you have correctly pointed out, I think in my practice also I'll see like maybe around 1 or 2% of flat feet might come for surgery. But I think what they need to understand is they need to understand their problem, and
So
if they
the
understand
difficult,
their problem,
I think the difficult ones are, I've seen a few at SRCC where you have somebody who's participating in under 13 and under 15, and that's a really young age, and they are at the cusp of district to state or state to national, and then they start getting this kind of pain. So even if you try and take them below threshold, you really don't have the time. So you have maybe 4 to 6 weeks there, and they do come back in a year's time or the next season with the same or similar complaints. Also, because this is a recurring thing, they generally don't tend to stick to the same physician, and they would have taken multiple opinions, and they've been subjected to MRIs and offered an arthroscopy. And those are the ones we really need to care about, and hopefully we'll have better solutions.
Yeah, but I think it's anterior knee pain and biomechanical changes are so much multifactorial that you can't address them with one solution, like doing an arthroscopy or doing just an insole or doing just one set of exercise. I think it's a kind of it's a multimodal approach where you need to address it at different levels. And I think nowadays with increased awareness about these problems, I think patients and their parents do understand these problems. And I think it's easier to explain now rather than maybe what I would say like 5 years back in our practice.
Perfect. Great. So we just have one question on the chat box. If there's anybody else who needs to ask us something, we can discuss that now. And there's someone who's written about what is the treatment for patients whose heel doesn't touch the ground and has a flat foot. So you'd
So,
want to
okay,
rephrase that,
okay.
right? Yeah.
Okay, so I think that's what I just mentioned. Patients whose heel is not touching the foot, touching the ground, and has flat foot. That means his Achilles or his gastrosoleus is tight, and that tight gastrosoleus, because the hind foot is everted, that's outwardly turned, is causing flat foot. So you need to stretch the gastrosoleus and then address the flat foot also. So flat foot can be happen like addressed with an insole or depending on that. The other very common cause, if this is a pediatric or an adolescent age group, then it can be a rigid flat foot where uh, the there might be a coalition or a peroneal spastic foot which is kind of taking the foot in eversion, and there is a super added gastrosoleus contracture. So it's very important that you start stretching gastrosoleus properly and then address the flat foot also. So you need to address it. In very resistant cases, say like someone who has a cerebral palsy kid or something, where the in spite of stretching, you might not be able to get the heel to touch down, especially in an adolescent or a pediatric age group. You might be justified in offering gastrosoleus lengthening procedure, which is like an ultrasound guided outpatient procedure. Add to that further, their improvement is seen in further there is a drastic improvement seen after this procedure.
Perfect.
So I think first
डॉगी
stretching.
किधर है?
Sorry. Right. Okay. Just another question. Will providing an insole in case of a flat foot affect the normal windlass mechanism?
No, because the flat foot is just like a support. The windlass mechanism is completely because of your intrinsic muscles, and it's important that you train the intrinsic muscles along with your insole prescription. So just giving insoles is not the solution or is not the correct way of treating it, or just giving exercises also doesn't support. So insoles will only support the bony structures. They do not affect the muscles which need to be trained by your exercises. So it's a combination of exercises and insoles.
How tarso-metatarsal disruption will affect patellofemoral movements? Like we're finding it difficult to connect.
Okay, so how tarso-metatarsal disruption? Because of tarso-metatarsal disruption, the medial arch can collapse. So now the root cause is tarso-metatarsal disruption, traumatic or whatever. That causes the medial arch to collapse. Medial arch collapse starts from the midfoot in this case, but affects the hind foot, which takes the hind foot into valgus, and hence the force vector in a valgoid hind foot will progress to medial knee and destabilize the patellofemoral joint. So that's the force vector how it's
So
going.
if you have an 8-year-old girl with flat feet and she has a borderline physiologic pathologic genu valgum, There's
Hmm.
somebody who's asked a question. If we start early exercises for flat feet in children, will there be lesser incidence of genu valgum that we see? Or can you
Uh,
reduce the amount of genu valgum with
I
correction of
think there is no documented evidence that by doing certain things. So these structural deformities happen primarily because of genetics, hereditary, and a small portion because of the force or the use of the muscles and the pull of the muscles also. So invariably, if you try and teach them exercises for your flat feet or also for your medial knee stabilizers, you don't promise the parent that it will change, but at least even if it doesn't change, the kid will be better equipped to deal with it dynamically. That means
At
the
what
muscle
age do
strength.
you actually see these patients and tell the parents, like, I'm sure most of them, when they're really small, they have this concern. So till what age do you tell them that, Arey, ye to bacha bada ho raha hai, just leave it?
So I see, say like till normally, 12 to 14 is where I would think about just plain exercises. 12 to 14. Two reasons. One, even if I have to intervene at, I
But
don't
what's the
intervene before.
earliest you will advise exercise? Like, do something
Earliest,
about
as soon as the patient is has the aptitude to understand the exercise. So it can
it.
be 5, 6, 7 years.
Right, right.
That's what they come.
Okay.
That's what at what that age they come, because they're school going kids. Their school going shoes are wearing off in a certain direction. While running, very common complaint is while running their knees knock against each other and the child
Hmm.
falls down.
Right,
So again, that is a combined problem of genu valgus and a flat foot. So
right,
many often than not, the pediatric surgeon will look at the knees and tell them that for the feet, insoles daliye or go to a prosthetist and orthotist and
right.
get an insole. But not all orthotists and prosthetists make children friendly insoles, and they make
True.
real grotesque insoles, which kind of is not acceptable to most modern age parents.
Right, right. So the other spectrum, ladies with high heels, with
Mhm.
calf pain and anterior knee pain. Do you want to touch that, or is that too huge a topic?
No, it is too huge a topic. But again, ladies with high heels will have calf pain because the foot is in plantar flexion. So there would be calf tightness. So they would have calf pain, or the Achilles tendon and all those things will pain. When the foot is plantar flex, the momentum or the center of gravity is slightly anterior. It's not in the middle of the knee in an AP plane also. So that movement of center of gravity anteriorly will overload the knee. So people who wear, or girls who wear high heels, will have calf tightness, will have quadriceps overfiring activity,
Right.
and hip flexor overactivity. So they need to kind of also, like, someone who's trained well to walk in it will know how to get her pelvic tilt
Yes.
posteriorly and walk properly so that the knees are not overloaded. For heels, calf pain is complementary. So you need to remove your heels and stretch at the end of the day.
So someone who's now again shifting the topic, I'm just reading the chat box and the doubts. Someone who's developed spasticity, plantar and dorsiflexion can be managed with sustained tendo-Achilles stretch. So how do you manage subtalar and other joints in the foot? So this is a very
Uh,
specific doubt.
so how do you manage subtalar and other joints in the foot
Hmm,
who
hmm.
is developing spasticity, as plantar and dorsiflexion can be managed?
Okay, I think we've again lost Abhishek there. So we're just 1 minute short of 6 p.m. and I would like to thank all of you.
Joint is actually
Yeah,
the toe
we'll let
joints, that
Abhishek
is the
finish off.
metatarsophalangeal joints. So
Right.
all the mid-tarsal
Abhishek, we
joints.
lost you for a bit. So if you can just repeat what you were
So
saying.
how do you manage subtalar and subsequent joints which are in the feet? That's what the question was, because dorsiflexion, plantar flexion can be managed by calf stretches. So you need to stretch, or you need to kind of balance these muscles by appropriate training. So someone who is plano valgoid needs to kind of strengthen the inverters. While you're doing the strengthening of the inverters, you need to stretch the everters. That means you need to passively uh, reduce the subluxed flat foot into a neutral and bring it more inwards. In a peroneal spastic flat foot, you will see a cord like peroneal tendons on the lateral side, which are a telltale sign that this, like, either you need to needle these joints or needle these tendons, or you need to kind of do a fractional release of this tendon. But that's how you need to do the subtalar joint. How do you do stretching of further, like tarsometatarsal and the intrinsics of the toes, is by plantar stretches. That's how normally there are strong plantar flexors and plantar fascia which can cause contractures and tightness. So you need to stretch them. While you're doing stretching, as someone just mentioned, you need to activate the windlass mechanism. So you make those plantar structures more taut. And then you need to start stretching with a foam ball, tennis ball, foam roll, tennis ball, or even a golf ball to stretch your plantar structure. So that's why you need to go specific joint wise, start proximally and go distally.
Super, super. Thank you for such enlightening comments and answers. And there's one more question on running, and I think we've taken a separate webinar on running injuries. Maybe we're going to take one for those who want to run, and what the foot surgeon and what the knee surgeon have to say for those who want to run, and how they can probably, we should drive the talk towards injury prevention more than anything else. So we will do that and answer that then. And again, thank you, Abhishek,
Thank you,
for
Miten.
the
My
time.
pleasure.
And thank you everyone to just logging in on a Sunday and spending an hour with us, and hope we've justified your time. Thank you. Bye-bye.
Thank you.